Okay, so we'll start making introductions now. Thank you, of course, for joining us this afternoon and this evening, depending on where you are in the country. Of course, tonight's presentation is Understanding Liver Transplantation for PKD and PLD patients. This is the first of hopefully many co-hosted webinars between the PKD Foundation of Canada and the Canadian Liver Foundation. So I would like to take a moment and thank Anisha Vij, who is with us today from the CLF. The two presenters this afternoon and tonight are Dr. Lilly, of course, and Jan Robertson. Dr. Lilly received his undergraduate and graduate training in physiology and pharmacology at the University of Toronto before completing his medical education at McMaster University. He then completed fellowships in internal medicine and gastroenterology in Toronto. Following a research fellowship at the Brigham and Women's Hospital in Boston in the laboratory of Dr. John Gollin, Dr. Lilly joined the multi-organ transplant program at the Toronto General Hospital, which has one of North America's largest liver transplant programs. He served as the medical director of GI transplantation, as well as the director of transplant hepatology fellowship program for many years. His main research interests include management and outcomes of research in patients with viral hepatitis undergoing liver transplantation. He has also served as the principal investigator in several trials involving immunosuppression and antiviral medications in the transplant setting. After we hear from Dr. Lilly, we will be joined by Jan Robertson. Jan was diagnosed with autosomal dominant polycystic kidney disease when she was 25 years old, some 44 years ago. In 1998, Jan underwent her first of two life-saving liver transplants from a deceased donor. Her birth liver was close to 40 pounds when removed. Jan required a second liver transplant, which took place in 2008 after a persistent bile duct infection caused the first transplanted liver to fail. She is now in the early stages of beginning to look for a living kidney donor in the hopes of bypassing dialysis. And lastly, after we hear from both of our presenters this evening, Anisha from the Canadian Liver Foundation will be joining the conversation and handling the Q&A. So of course, as usual with our webinars, there is the Q&A box at the bottom of your screen. Feel free to enter your questions throughout the presentations. We will have a live Q&A after the fact. And if there's anything that comes up throughout the presentation, you can drop it in there, or you can add it in later in the conversation. This presentation is being recorded, so there's no need to make panic notes throughout. It will be available for your viewing pleasure after the fact. So without further ado, I would like to welcome Dr. Leslie Lilly to the conversation.
Okay, Jeff and Jan, thank you very much for inviting me to be part of this evening, or this afternoon, as you keep saying. I'm just thinking I should have probably had some theme music, given that we're here in Toronto, and I was thinking that maybe Smoke Gets in Your Eyes would have been good music to have played in the background here, given that we now have, as of this afternoon, the worst air quality in the world here in downtown Toronto. I'll just bring up my slides here. Jeff, can you confirm that you can see that for me?
Yes, I can.
Okay, excellent. Okay, so I've been tasked with the job of trying to clarify the role of liver transplantation in polycystic liver disease, and I thought that I would sort of start from the basics and talk about liver transplantation in general, because I'm assuming that most of the people in the audience are not going to be familiar with it, and then focus in at the end on polycystic disease and the unique challenges and aspects that it brings to the transplant setting. They've given me a lot of time to do this, and I don't think I'm going to use it all, although Jan certainly knows that if you give me half a chance to talk about transplant, I'll take a full hour to do so. So I will try and hold back here. I did join the liver transplant program at Toronto General in 1995. And we just did our 4,300th liver transplant the other day, and I've been there for about 3,850 of them. And it's included a fair number of polycystic patients, not Jan's first, but certainly her second anyway. So back to basics, if this will work. I'm going to talk very general terms about liver transplantation and what it is. And I will review the usual reasons that we offer liver transplantation to our patients, because I think it's important to understand that before we focus in on the somewhat unique indications in patients with polycystic liver disease. I'll review the outcomes of liver transplantation in the general setting, and then I'll focus on the outcomes in patients with polycystic disease, and then wrap up and kind of come back to the primary question, which is to clarify the role of liver transplantation in this challenging setting. So this may seem kind of obvious. Liver transplantation has been around since the 1960s, but became the standard of care for the management of a long list of liver disease in the late 1970s and early 1980s. Canada's first program opened in 1983 in London. Our program opened in 1985. And Toronto is, for 2 years, in the last 3, was the #1 liver transplant program in North America. Liver transplantation involves replacing the patient's native liver with all or part of another liver obtained from either a deceased or a living donor. When we receive an offer from a deceased donor, we typically use the entire liver. However, we have become very comfortable in using bits and pieces of livers. Occasionally, a deceased donor will have a high quality liver that allows us to transplant 2 different patients, often a child and an adult. And as I'll show you in a couple of minutes, our program has established a long tradition of very highly successful outcomes in patients using living donor grafts as well. So basically, you take the patient's liver out, you put another liver in its place. The abbreviation for this process is called orthotopic liver transplantation. Ortho means the same as, topic means place, and liver transplantation. So unlike kidney transplants, which do not go in where the old kidneys were, liver transplants by necessity go in where the old liver was. As I've already mentioned, there are 2 routes to reaching the goal of receiving a liver transplant. One is through living organ donation, and the other through deceased donation. Living donation for liver transplants in adults was first done in the early 1990s. Our program started in 2000, and Toronto has the largest program in the Western world for living donor liver transplantation, with well over 1,200 procedures to date. Deceased organ donation is a long-established treatment for end-stage liver disease, including patients with polycystic disease, and still represents the majority of transplants in the Western world. If, however, you go to countries like Korea or Japan, over 95% of all transplants done in those countries are done using living donor grafts. So what we consider to be unusual in the West is considered absolutely the standard of care in the East. This is our program, and I'm showing you this for a reason, because I'm going to come around to where polycystic liver disease fits in this. Our program, as I mentioned, started in 1985 with 2 whole transplants, and we've been running around 200 transplants a year for the last several years. The orange bars are representing the deceased donors. The vaguely purplish bars are the living donors, and you can see that from our living donor program first year in 2000 or 2001, it's now grown to become, in most years, 25 to 30% of all of our transplants. And we do have a number of patients with polycystic liver disease who've actually been able to undergo living donor liver transplantation. And I'll make a brief mention of that in a subsequent slide. Now, these are the main reasons that we do liver transplants. I've taken 5 years of data here. Obviously, it's a bit of a moving target. For example, hepatitis C continues to disappear as an indication for transplant, thanks to the development of highly effective therapies. But over that 5-year period, it was about 15% of our patients. Alcohol was about 25%. Fatty liver was, in yellow, was about 20%. And I'll show you what's happened to those numbers. And if you look at the fine print at the bottom of the screen, you'll see other. Other includes liver disease due to TPN, which is parenteral nutrition, a congenital disease called alpha-1 antitrypsin deficiency, a clotting problem called Budd-Chiari-Wilson's disease, and there it is. Polycystic liver disease falls into the other category. So you can already see that the others make up 7% of our transplants, and this is only one of many others that we do. This was about 1,000 patients included in this slide. And so let's just keep that in mind, that polycystic disease is considered a fairly rare indication for liver transplantation, not just in our program, but in most of the large programs in the West. So most of the patients that we transplant with livers have cirrhosis, which patients with polycystic disease do not. These patients most commonly have cirrhosis due to a prolonged exposure to alcohol or to fatty liver. Fatty liver disease is the most rapidly growing indication for transplant these days. And so if you take alcoholic liver disease and fatty liver disease together, and it makes up about 60% of all the transplants that we do. Despite the advances in antiviral therapy, an area of interest of mine, patients with end-stage liver disease due to the two big viruses, hepatitis B, HBV, and hepatitis C, make up about 18% of our patients. And there are 3 diseases that are typically lumped in as autoimmune diseases. They're abbreviated PBC for primary biliary cholangitis, PSC for primary sclerosing cholangitis, and autoimmune hepatitis, AIH. And they make up about 12%. And that's about 90%. Let's see, 60, 18, 78, that's 90% of our transplants. It's important to remember that liver cancer, which is unfortunately a common complication of cirrhosis, often drives the transplant process. Again, this is not the case in patients with polycystic liver disease. So of all the patients that we transplant for those diseases, alcohol, fat, Hep B, Hep C, the autoimmune diseases, almost 40%, it's actually liver cancer that's driving the transplant process rather than liver failure itself. So that's 90% of our patients. The remaining 10%, is that slide I just showed you demonstrated, includes acute liver failure, which is about 3 or 4%, and a variety of congenital or metabolic disorders, including Wilson disease, which is a copper accumulating disease, hemochromatosis, which is an iron accumulating disease, biliary atresia, which is a congenital disease where the bile ducts do not form normally in utero, cystic fibrosis, which most people know what that is, sickle cell disease, which even here in Toronto we have a few cases, alpha-1 antitrypsin deficiency, another metabolic disease with which people are born, polycystic liver disease, and another dozen or so other diseases. So polycystic liver disease, while a well-recognized indication for transplant, is a very rare reason for patients to undergo transplant. And it's important to recognize that it does not get lumped in with those diseases that are associated with liver failure or liver cancer, which is what drives the vast majority of our transplant cases. In fact, the principal indication for transplant in patients with cirrhosis is liver failure, with an average survival of about 2 years without transplant once the patients are listed having fulfilled criteria. I just have to respond to a quick text here. As I mentioned already, after liver failure, which is the majority of the cases for which transplant is offered, liver cancer is the second thing, about 40% of our cases, and these patients would have an anticipated survival at 5 years of essentially 0 without transplantation. So we offer transplantation typically for patients who are going to die if they hang on to their original livers. And we fulfill what are called minimal listing criteria. We look at the patients and say, well, how long is this person going to live with the liver they brought with them today? How long would they live if we gave them a new one? And if there's a clear advantage to transplant, then it is offered. Now, transplant carries risks. The risk of dying in the operating room during a liver transplant is typically quoted at between 2 and 4%. I think that's probably a generous estimate these days. It's probably between 1 and 2%. And in our own program, 8% of our patients will have expired of complications within the first year. So the survival 1 year after a liver transplant, and I have pictures of this, is about 92%. When your survival at 1 year in the absence of a transplant is far less than that, the risks of transplant actually can be justified when you put them against the benefits. And transplant in general is offered for quality of life. We transplant patients to make them live longer, not necessarily to make them feel better, Although I'm pleased to report the vast majority of patients actually do feel better once they've been successfully transplanted. So again, this refers to the 98 point something % of transplants that are done in patients pretty much without polycystic disease. And this, just to illustrate this, you can see here, this is data that's now a little bit old, but this is about 2,700 transplants in our own program. You can see that if you look at the patient survival curve, which is the blue line, you can see that the 1 year survival at this point for patients was just a little under 80, just a little over 88%. It's gotten better since then. The 5 year survival was about 80%. This included a lot of patients transplanted for hepatitis C, which used to come back and trash the liver. Sorry, guys, 1 sec. Ian, I'm actually giving a talk. Can I call you back? Okay, thanks. Okay, bye. Nobody ever needs me this much. And so this is the results that our patients can expect after undergoing liver transplantation. Patient survival in the order of 90% at a year, and patient survival at the order of 80-odd% at the 5 year mark. And if you break it down by disease, you can see the red line is patients with alcohol, the green line is patients with Hep C. And if you look at the little graph at the bottom, the little box, you can see that Hep C at 5 years is 80%, Hep B is 80%, alcohol is 82%. And I put this up because what we're essentially asking our patients to do is to say, well, let's imagine that you don't have a liver transplant for your disease. What are your chances of being alive at 1, 2, 3, and 5 years? And what are statistically your chances of being alive if we do give you a transplant? And that again goes back to that whole concept of minimal listing criteria. You know, I say to my patients in the clinic room, I say, okay, let's imagine that there are 100 of you in this room right now. And then I always make a joke about how the public health people would be very upset with us if there were, especially during COVID. And we transplanted 50 of you, and we left the other 50 to the best medical care that they could get. At the end of a year, which group would have more survivors? And that's what we mean by minimal listing criteria. We use other criteria as well. We use something called the MELD score. We use something called the Child's Q score and things like that. But essentially, if you wanted to estimate someone's transplant survival benefit, because this is a life-saving procedure, you try to guess what their survival would be with and without a transplant. And that's basically my job when I see patients in consultation in the clinic. Even our cancer patients do quite well. This is a disease that has a 0% 5 year survival. And you can see with transplant, the patients actually have close to an 80%, the blue line, 5 year survival with transplant. So the best treatment for liver cancer in the vast majority of patients is liver transplant. And we just don't have enough organs to offer it to all the patients that would benefit from it. So let's talk about the indications for transplant in patients with polycystic liver disease. Now, polycystic liver disease, the commonest type, of course, is the autosomal dominant polycystic liver disease, which Jan, of course, has. And the incidence worldwide is reported to be somewhere between about 0.25% and 1%. So in a country of 40 million people, such as ours, 1% of those people have polycystic kidney disease. And about 80% of that 1% will have also polycystic liver disease as well. In type 1, most of the cases, it affects both the kidneys and the livers. And you find cysts, of course, all over the place as well. But when we look at the patients that are sent to us for transplant, only a minority of those patients actually have the typical signs of liver disease: ascites, which is abdominal fluid building up, jaundice, the yellow eyes, confusion, which in liver disease is called encephalopathy, sometimes biliary tract obstruction. These patients from the foot of the bed look a lot like patients with other liver diseases. And for these patients, the transplant survival benefit is very clear, and transplant is clearly indicated. However, as you probably know, in most cases of polycystic liver disease, liver function is actually normal. Somehow, stretched between all those cysts, the dozens and dozens of cysts, there are enough healthy liver cells to actually do the job that the liver is supposed to do. So most patients with polycystic liver disease, if you just look at their blood tests, you'd say, well, what's the big deal? Their liver works normally. And so because we estimate the mortality of liver disease based on the severity of the deranged liver tests, the survival from a liver point of view for most patients with polycystic liver disease is not dramatically different from the general population. So the usual indications in patients with polycystic liver disease revolve around the mass effect, the size of the liver, a liver that may be 10 times the size of a normal liver or even more. And this mass effect can present with early satiety and the associated malnutrition that goes with it. Many of our patients are quite wasted. Abdominal fullness with a limited ability to climb stairs, to walk long distances, to do any form of regular exercise. And many patients are so full that they're in pain, and those patients actually may end up even on prescribed doses of narcotics to control their pain. These patients are not going to die of liver failure. These patients are miserable because their livers are massive. But speaking in the same terms I used before, this is more of a quality of life than a quantity of life issue. So we are talking about most patients who have liver transplants have them because they're going to die in the absence of the transplant. Most patients who have liver transplants for polycystic liver disease, their mortality, at least in the short term, is not that much worse than that of other patients in the general population. So when I talk to patients with polycystic liver disease, the discussions focus on balancing those risks of transplant, including the surgery itself, which I've talked about, but also the risks inherent in taking immunosuppressive medications with all of their wonderful side effects for 10, 20, 30, or 40 years afterwards. And this is the focus. So the usual criteria of minimal listing, better survival at a year with a new liver than with the one you brought into clinic with you, don't typically apply. And it has to do with this nuanced discussion around risks versus benefits. So does it work? Well, of course it works. I looked up a couple of large series. There's a series published in 2011, which showed a 5-year survival rate after a transplant for polycystic liver disease of 92%, which is actually better than what we get overall, given that our 5-year survivals tend to be these days just over 80%. And another more recent series, which showed a 5-year survival of about 85%, which is pretty much in line with what we get these days as well. So the former numbers are better than typical indications for transplant, and the latter numbers are comparable to what we get these days, a little worse than what we get for some of our patients with diseases such as PSC, sclerosing cholangitis, and hepatitis B as well. However, the most important thing, of course, is to examine what the survival of these patients was going to be in the absence of a transplant and compare it to what their survival is likely to be in the presence of a transplant to convince us and the patient that it makes sense to go ahead. And given that in most patients with polycystic liver disease, it's not a life-threatening liver disease, these numbers have to be kept very much in mind. So again, it comes down to risk balanced with benefit. Now, I joined a study some years ago where I thought it would be useful to look at our experience in Ontario. So this is real life data, and this includes patients who were transplanted for the first time. So Jan, you missed out in this study, from January of 2000 to April of 2017. So we found 51 patients between the two programs in Ontario, on Toronto and London, Ontario, who had undergone liver transplantation for polycystic liver disease. Patients who were retransplanted weren't included. Patients who, some of them had been lost to follow-up and things like that. Some of them had other indications, but we came up with 51 patients, and the total number of transplants done in Ontario over that time was a very impressive 3,560, meaning that polycystic patients made up 1.4% of all of our transplants. Not a big number, and that has to be kept in mind in terms of doing a statistical analysis. 43 of those patients were women, and 8 of those patients were men. And I think that if you look around you, you probably, if you could see each other on the screen, you probably would reflect that. And the men tended to be older. The men were on average 62 years of age, and the women were on average 52 years of age. There were a few cases that were done for the usual signs of liver failure, but the vast majority, at least 80%, were done for the mass effect issues around polycystic disease. And I dug into the data a little bit. 29 of the patients had a liver transplant only. 15 of the patients had a liver transplant after they had previously had a kidney transplant, and 7 of the patients had them at the same time. And the situation there is often that the person goes on dialysis, they need a kidney. We assess them at the time about what impact is the liver having on this person's function. And often it makes sense using a single deceased donor to proceed with a simultaneous transplant. So that's the breakdown here as well. Now, you know, the waiting list system for at least for the last 12 or 13 years is based on something called the MELD score. MELD score looks at your bilirubin, your INR, your blood clotting, your kidney function, and your sodium values. And most patients with polycystic liver disease have normal liver tests. So if you put them on the waiting list, they're going to occupy the basement forever. So the patients actually, to get transplanted, have to be given extra points. So the patients are actually given as many points initially as patients with cancer. And people have commented that Ontario is really very generous in terms of being able to transplant these patients. Of the 51 patients that I described here, 5 of those patients received living donor grafts, all of them in Toronto, of course, and 46 received deceased donor grafts. And the average follow-up when the series was put together was 6-point-something years. So some of the patients, of course, it was 15 years or 16 years. Some of the patients, it was a year. On average, it was about 6 years. So you have to bear that in mind when you look at the outcomes. At the time the data was collected, 4 patients out of the 51 had died. All those deaths were late deaths, or more than a year post-transplant, giving you a 96% 5-year survival, which is actually not that different from one of those series I reported earlier. So liver transplantation for the 47 survivors was highly successful. And although if you do the statistical analysis, this isn't better than overall simply because you're comparing 51 patients to 3,500 patients, it's clearly not worse. And to the eye, at least, it looks somewhat better as well. Now I threw in some of my own information. One of the patients that was included in this series, who had a living donor liver transplant, went on to have a kidney transplant and then died, unfortunately, in the last year or so of breast cancer. And we know that immunosuppression, unfortunately, hastens a number of malignancies, including breast cancer and things like that. So the long course of immunosuppression probably was a factor in her ultimately succumbing to her breast cancer. We did a patient shortly after the series was collected who received a combined liver kidney transplant, and he died in the first couple of months of infectious complications. And another lady that we transplanted in 2018 or early 2019 received a liver only, but died of progressive neurological complications at 3.5 years. So there have been more deaths since the series was collected. We have another 11 patients in Toronto that I could find since then, including the one that we just did on Saturday. She's still around, at least as of this morning, and they've all survived. It's important to recognize that it's not perfect. And that for the gentleman, for example, who had a liver kidney transplant, who died a few weeks later, it's very likely that we dramatically shortened his life. He got off dialysis briefly. He was relieved of his massive liver. But the concern, of course, is when you use these organs, scarce as they are, in patients like this, that balance, again, of risks versus benefits. So what is the role of liver transplantation in polycystic liver disease? Well, as I've demonstrated to you, most patients with polycystic liver disease will neither develop the usual indications for liver transplant or even the very unusual indication seen in this disease. As I said before, if you believe it's 0.5% of the Canadian population of 40 million, there are thousands of patients out there with this disease. And yet here we are, the largest program in the country, the largest program in North America, and it makes up 1-point-something% of our transplants. When these patients are listed for transplant, unless they have a living donor, they do require these exception points, which means that they are considered to be at the same risk of dying as patients with cancer, which we know isn't true. And inevitably, these patients will go on to receive organs from the deceased donor pool that might have otherwise been implanted in patients with liver failure or liver cancer who were more likely to die of their disease. Now, polycystic liver disease is one of the very few diseases that we can cure with a transplant. We can't cure viral hepatitis, we can't cure alcoholism, we can't cure fattiness, we can't cure autoimmune diseases, but the new liver does not start filling up with cysts again. So that's a very big positive sign. However, we have to factor in the negative effect of the surgery itself and its attendant risks, and the lifetime of immunosuppression, which unfortunately certainly contributed to the deaths of those patients that I described on the previous slide. So I don't want to use the term last resort, and I don't have polycystic disease. That's why Jan is talking after me. So I don't want to minimize either the negative effect of the disease on someone's life or the positive effect of transplantation thereafter. But in most cases with polycystic disease, the patients are considered for transplant only after a variety of medical treatments that have come along, a limited number of radiological treatments such as fenestration or cyst drainage, and even a few surgical treatments have at least been considered, and in many cases have been attempted in these patients. So the role of liver transplant in polycystic disease is limited. Bearing that in mind, however, the results are at least as good and probably superior to transplant for other indications. And I think that's my last slide, and I doubt I used up all of my time. Thanks a lot.
Well, thank you, Dr. Lilly, for that fantastic lecture. As we can all appreciate, Dr. Lilly is a very busy man, and tonight is no exception. So he is on call this evening, which he forewarned us prior to jumping on. So we're very thankful that he was able to make it through the presentation and hopefully can stay with us through the Q&A. Next up, I would like to introduce my mother, Jan Robertson, who is a two-time liver transplant recipient. Jan will be sharing her story about living with both polycystic kidney disease and polycystic liver disease. Over to you, Jan.
Good evening. It is a real honor for me to be able to speak to you tonight as a PKD and a PLD patient and survivor, having been diagnosed almost 44 years ago. And also, as Jeff mentioned, I am a double liver transplant recipient. When I was diagnosed at 25, I had no idea what lay ahead for me. My liver disease was discovered when I went to a surgeon following the birth of my first child. There was a complication that needed looking after, and before he did the procedure, he gave me a small physical. He noticed that my liver was slightly enlarged, and he asked me if I'd ever had hepatitis or jaundice, to which I replied no. He said that he really wasn't concerned, that I was very young and seemed very healthy, and sometimes during pregnancy the organs can enlarge, and it takes a little while for them to go back to normal size. But after he did the procedure, he decided that it might be a good idea to do an ultrasound anyway, just to double check. So what happened was I went to the hospital a couple of weeks later, and by the time I got back to his office, which was less than 5 minutes away, the hospital had already called him and told him that my liver and kidneys were covered in cysts and they had no idea what was wrong with me. He was very shocked, to say the least, and so decided then that further investigation was necessary. So a couple months later, he booked a laparoscope, and that's when it was determined that I had polycystic kidney and liver disease. I continued seeing this doctor for 2 years, but then he informed me that he could no longer look after me because he was a surgeon and surgery was not going to fix this problem. So in the early years following, after I left the surgeon, I saw many doctors, but unfortunately, they were not familiar with my liver disease. I would go for appointments every 6 months, and every time I went, they would measure my belly. They would tell me that I had gotten worse, that the liver had grown, but it didn't matter what I ate or what I drank, that there was nothing that they could do to help me, and gave me no resolution as what was going to happen in the future. It was a very frustrating and lonely part of my journey. Years later, I learned about a Dr. Janet Roscoe, and Doug and I went and had two wonderful appointments with her, and it was the first time ever that Doug and I felt that there was any hope for our family and for me. But on my second appointment, she referred me to Dr. Gary Levy at Toronto General Hospital, and he was wonderful. And at my first appointment, he informed me that I would need a liver transplant sooner than later, and it was probably a good idea to go on the list right away. I never thought that this is what was going to end up saving my life, but we started the pre-transplant tests, and by November 1995, I was on the list. And it's a good thing that I did go on the list when I did, because I ended up waiting for 2.5 years. Originally, Dr. Levy was hoping it would only be about a year, but as the list grew and there was emergency transplants that needed to be doing, it took extra time. During this 2.5 years, my liver continued to grow. And as Dr. Lilly said, it was becoming very difficult to do anything, cleaning, driving in the car, walking any distance. Even bending over was a huge problem because my liver was so humongous. And if I did bend over, very often it would cause cyst breaks, as the liver would rub against the ribs or get stuck underneath the ribs and cause the breakage. When the breaks happened, it was very, very painful and sometimes debilitating. I remember one night I was downstairs in my recliner and Doug was putting the kids to bed. And I must have turned the wrong way, because even turning sideways sometimes could cause it. And I was just in excruciating pain, and I couldn't even get out of the chair until he came back downstairs to help me. When I was sitting, my liver would rest on my lap. It was so big. During my wait, I had to carry a pager with me so that they could inform me when a liver became available. I had many false alarms during those 2.5 years, and it usually happened when I was out to dinner with friends or family, which caused great excitement until we knew whether it was the real deal or not. I remember one night we were at Ed's Warehouse in Toronto, and our meal had just come to the table when the pager went off. So Doug asked the server to please take the meals back to the kitchen so that we could, because we might have to leave immediately. And the one friend that was with us just started eating as fast as he could. And his wife asked him how he could possibly eat at a time like this, but he said that if we were going to spend the night in the hospital, he was going with a full stomach. On February 21st, 1998, I received the call, and we were told to get down to Toronto General as soon as we could. Both the kids were out that night. Jeff was at a prom, so I had to go and find him and give him a hug and say goodbye. And our daughter was at a restaurant at a birthday party, but luckily it was on the way down to the hospital, so we were able to stop in and see her too. When we got to the hospital, there was lots of blood drawn, chest x-ray, lots and lots of appointments and discussions with doctors and nurses and the surgeon. But unfortunately, the surgeon came back in the next morning and informed us that the liver was not viable. So this became my dress rehearsal, and so that I knew what to expect the next time. 2 months later, on April 25th, 1998, I received my first miracle, and my life changed forever. I was able to do things physically that I hadn't been able to do in years and years. My size went from a size 18-20 down to a size 6. So I was thrilled because it meant all new clothes for me. And I didn't have to explain on a daily basis to everyone that didn't know me when my baby was due. We're not sure exactly how much the liver weighed because at that time I was really quite thin, and the liver was so huge that when they took it out, a lot of the cysts broke and the fluid came out. So they couldn't get an exact weight, but I was told when the liver was inside, it was probably around 30 pounds or so. Dr. Roscoe, who had referred me to Dr. Levy, had a sister, Dr. Brissenden, who did research in PKD, and she had asked if she could have the liver when it was extracted because she wanted to do research on it. So she kept part of it. Part of it was sent to Montreal, and part of it was actually sent to Europe. I did have concerns, as Dr. Lilly talked about, with the medication before I had the transplant. I had heard some not very good things about it, but I have been very, very lucky with the medication, and I was on pretty high doses when I first had the transplant, but I was really pleased at how quickly the dosages were reduced, and a lot of the medications were actually stopped altogether. My recovery from this transplant was great. I was up and around in no time, and I was able to be home by May 5th. I had weekly visits to the liver clinic at Toronto General and weekly labs done in my hometown. I did a lot of walking. One of my best friends across the street had just had surgery the day before my transplant for ovarian cancer. And as it ended up, we came home almost at the same time, and we were able to recuperate together and heal together. And we walked around our neighborhood, and it was wonderful for both of us, and it made us both so much stronger, and it was very important. At 6 weeks, I was able to drive again, but I wasn't able to do anything like vacuuming or heavy lifting or anything of that nature for up to 3 months. As the medication doses decreased, so did my visits to the hospital, to clinic. They got less and less, and as did the blood visits. I loved my new life, and it was the first time I had felt normal since that fateful day when I got the diagnosis. I saw both my kids graduate and go on to have wonderful careers helping other people. I got to spend precious time and years with my parents. I got to celebrate with friends and family, all their special occasions and all holidays. And it was absolutely wonderful. I became a mentor for the transplant program at Toronto General, and I also was a mentor for the PKD Foundation for both liver patients and kidney patients. And we started the charity in 1994 because it had been such an awful experience for me when I was first diagnosed, not knowing anybody who had it, not being able to talk to anybody, not having any medical help with knowing what was going on with me. So it was really important to us to start the charity. It's now the PKD Foundation of Canada since Jeff became ED 15 years ago. It's a national charity with chapters all the way from Vancouver to Newfoundland, and we do webinars and seminars and symposiums, and it just is so heartwarming for me that the patients now are able to have that support, which I wasn't able to have. I did great for almost 10 years. We were planning a party, but then very suddenly I got very sick. Within 5 months, I pretty much had 1 day to live. I spent almost the entire 5 months in the hospital. I would come home once in a while for a few days, and Dr. Lilly would always tease me because I always ended up back there on a Friday night of the long weekend, and there was nobody there to look after me. I had numerous blood infections and abscesses on the liver, and it was constant MRIs and ultrasounds and blood draws and appointments with both teams, the liver and kidney teams. As Dr. Lilly said, at one time there was a discussion about doing a double transplant, but then it became evident that the liver was in such crisis and there wasn't time to wait for a donor, that I could get both the liver and the kidney. So if a liver became available, I needed that immediately, and because I could always go on dialysis. At the beginning of the 5 months, there was a specialist at St. Mike's Hospital who did a special procedure on bile ducts, which is where the problem was. And so they booked an appointment for me to go and have surgery there. But when I woke up, the doctor was standing there with tears in his eyes and informed me that that was no longer an option. He couldn't do this procedure or help me. He'd already called the transplant team at Toronto General, and they were waiting for me in Emerge. So Doug and I headed right over there, and sure enough, there was 5 doctors waiting for us. They escorted us up in the elevator to the 7th floor and informed us that transplant was the only option. And so on the list I was again. The last 2 weeks before, or the last 2 or 3 weeks before I had the transplant, I was in ICU. And my family was with me 24/7 because we really didn't think that it was maybe going to have a positive outcome. And I was so thankful that I had that time with all of them. On March 30th, 2008, I received my second gift of life. And I know for a fact, if it hadn't been for Dr. Lilly, I wouldn't be here today. After all the years of doctors that didn't help me, I won the doctor $1 million jackpot with him. He has been by far the best doctor I have ever had. We have been partners in my health for over 25 years, and I am so blessed to have such a caring, wonderful doctor. And I know he is always there for me and always puts me first. This recovery was much more difficult. As I said, after spending several weeks in ICU, pre-transplant, I was not able to walk. I was not able to eat. I couldn't do anything for myself at all. And also 3 or 4 days after the transplant, I had an internal bleed, and they had to go back in and do surgery again to find the source of the bleed. So it was 2 major surgeries in a very short time, which also complicated the matter. Post-surgery, it was a real challenge, learning to walk, learning to eat, and just do any of the smallest life things. They gave me a walker at the hospital about 2 weeks after the surgery. I couldn't even stand up at first, so there was a lot of physical therapy. And finally, I was able to learn to walk with the walker, and I came home with the walker and used it for a very long time after I got home until I could walk on my own again. I had no taste at all. No appetite. It was terrible. And I had lost almost 60 pounds in those few short months. So I was extremely thin and weak and had no stamina whatsoever. A very dear friend of mine had also been a double liver transplant recipient, and someone had told her that if you use plastic utensils, sometimes that helps. So I started doing that. I was so desperate, and sure enough, that was the one thing that finally allowed me to start being able to get some food in. And but it took about a year to get my weight back and my strength back. It was a long haul, that's for sure. When I went to my first clinic after the second transplant, there had been an incredible young nurse named Jeff in ICU. And when he saw me there, he came running over and gave me a huge hug. And he said, "Girl, you were knocking at the door." To which I replied, "Thank God no one answered." And the resident that took my staples out said that he felt he would never see me on the other side of the clinic. It's been 15 wonderful years now since Miracle 2.0, and my new liver is very happy. However, the kidneys, not so much. 25 years since my first one, which I just celebrated in April. And Dr. Lilly kindly reminds me that it took me 2 times to get there, but I'm still very proud of that. The PKD has progressed, and the 25 years of anti-rejection drugs have certainly affected the kidneys. So I am functioning now at just 20 and just above 20. It fluctuates a bit. So I think my next transplant will definitely be a kidney, and hopefully it'll be sooner than later before I get too much older. My hope is that we will be able to find a cure by all working together for PKD and PLD. And my hope is that this will happen in my lifetime and that my polycystic journey will be complete. I know for a fact that my 2 transplants are the best thing that ever happened to me and have allowed me to become a Grammy for the past 8 years and live life to the max. Take care all, and thank you.
Thank you so much for that, Jan. That was a very moving story about your experience, and I really appreciate from our organization, and I'm sure from Jeff and his organization, being able to share your story. So just jumping into our Q&A, we do have a few questions. Our first question here is for Dr. Lilly. Back in the day, transplants for enlarged livers took quite some time to be approved, given the function could still be high, even with substantial volume. So what advice do you have for patients who suffer from the added weight of an enlarged liver, whether that be back pain, heart issues, general discomfort, who aren't able to be added to the list just yet?
It's a good point, because as I mentioned, transplantation is kind of the last step that we offer. I have to acknowledge I only do transplant. The only patients I have ever met with polycystic liver disease are patients who are either waiting for a liver transplant or who have had one. But I do know many patients that have come to us after a number of trials of medical therapy. Some of the patients that have come to us have actually had to have tubes placed in their nose to make up for the nutritional deficits. There is a limited role for some interventional procedures, such as embolization of one of the arteries that branches into the liver, or cyst resection or cyst removal. But I'm not qualified to give much more direct advice than that, because I'm so painted into my little corner. Again, I think that transplant could be considered earlier in many of these patients. That doesn't necessarily mean that it should be done earlier. The criteria for several years ago, the Trilling Gift of Life Network actually removed a minimum MELD score as a criteria for listing for transplant. So we actually can list patients for polycystic liver disease, even if their liver tests are totally normal. And we've made the process of getting exception points for transplant automatic. So there's no committee review or anything else as well. So I think over the years, it's evolved to the point where it's easier to be seen for transplant and easier to be listed for transplant, and a little bit more predictable than Jan's 2.5 years to actually get a transplant. Even though, as I said in my presentation, I think the role of transplant in this particular disease has to be very carefully considered within the context of all other transplants and within the context of all other treatments.
Thank you. One more question for you from Jacques, which is a little bit more specific. Can you speak at all to the medical treatment alternatives, and have there been any progress on that front? For example, what do we know about sandostatin?
Well, I mean, honestly, I can't. There's a literature on the use of the somatostatin analogs such as sandostatin, and there seems to be only limited benefit in patients. There was a big fad for a while for using drugs called mTOR inhibitors, and those have their own sets of side effects and are of limited usefulness as well. But no, I'm not qualified to address that. You need to speak to a more general hepatologist. It used to be Dr. Morris Sherman, who's now retired. It's usually Dr. Jordan Feld these days, who has an interest in polycystic liver disease. I'm not qualified to speak more to that.
Okay, thank you. A question for Jan. Having mentored patients with PKD and PLD for many years, I think you had said 30 years, what advice do you have for patients waiting for a liver transplant?
I think the best thing to do is to talk to somebody else who's been through it. I think, you can talk to anybody, any professionals, and not taking away from any, medical staff at all. But I think it's so important that you talk to somebody who's actually lived it and walked in your shoes. And as I said, that's why we started the charity all those years ago, was because of my experience and what I'd gone through after diagnosis, and not having anyone I didn't know a soul that had it. And every time I asked a doctor about it in those days, no, I don't have any patients with this. No, I really can't help you. I don't know anything about it. And like I said, they would measure my belly, tell me I was worse. It didn't matter what I did, you know, what I ate, what I drank, they couldn't help me. And now we know so much more. It's just incredible, the advancements that have been made since I was diagnosed. So I think that's the main factor. And I'm more than happy to talk to anybody about it. I love doing that and sharing my experience, because even though the second one was pretty difficult, I just feel so blessed to be here all these years later. So
Absolutely. And kind of just a little bit more of a personal question. What has your quality of life been pre and post transplant from both of those liver transplants?
Like I said, after the first one, it was wonderful for 10 years. My whole life changed overnight. I got rid of this burden that I'd been carrying since I was 25 years old. It was wonderful. Everything was perfect. But then, like I said, I got very sick very suddenly. And even though it took a long time to recover from the second one, I've had 15 wonderful years again and been able to do so much more than, you know, I would have ever been able to do had I not had them. And like I said, you know, I know for a fact that Dr. Lilly is a big reason that I'm here today. And I cannot thank him enough, and I'm really not looking forward to the day when he's not there anymore. That's going to be a real tearjerker for me, that's for sure.
Jan, you made it pretty easy, because you actually do most of the things I ask you to do.
That's good. That's good. That's because you're you. That's why I do it.
Question for Dr. Lilly. I know we had talked about some lifespan statistics earlier in terms of percentages and, you know, how much of that population that will have a transplant would be still alive after, you know, a year or 5 years. But looking overall, what is the average lifespan of someone after a liver transplant?
Okay, I mean, I think that's a pretty easy question to answer. The average person that we transplant is about 54 or 55 years of age, if you look at all comers. And the average life expectancy now is just about 20 years. So, I mean, 20 years ago, we weren't saying that to our patients. I mean, back in the olden days when we were first doing this, we were just grateful if most of the patients made it out of the hospital. But I think it's safe to say, I mean, the numbers I give to the patients is that 90% will be alive at a year, 80% at 5 years, 70% at 10 years, 60% at 15 years, and about 50% will be alive at 20 years. It's a little bit approximate, but that's about what we quote these days. I mean, obviously, if you're transplanted when you're 18 or transplanted when you're 71, you know, you have to modify those numbers a little bit as well. We have a gentleman who is just celebrated his 40th anniversary with his transplant. He was transplanted as a child. And I have a lady who will be 37 years out from her transplant as an adult later this year. So we do have some long-lasting patients. And I always say to the patients, you're going to tell me how long a liver transplant patient can last. It's far be it for me to tell you.
Okay, fantastic. It sounds like there's some promising numbers there. Question for Jan. What have been your kind of biggest hurdles post-transplant after all of kind of the medical things were dealt with?
I think the main thing is you have to be very careful as a transplant patient about being around sick people. I'm probably on the extreme side of that, and COVID didn't help at all. It just made it worse. We pretty much hibernated for 3 years and didn't go anywhere, or didn't see anybody or do anything. But even under normal circumstances, I was very careful about, you know, who I was with. If somebody was sick, no thank you, I'll see you later, that type of thing. But really, you know, you can have an incredible, wonderful life, you know, post-transplant. And you just have to be cautious. And like Dr. Lilly said, you have, you know, there are certain things you have to do. You have to make sure you take your medication, you know, at the regulated times. You know, you have to drink the amount of water you're supposed to drink, you have to eat healthy, you have to exercise, things like that. But you should be doing that anyway, whether you're, a transplant patient or not. So I would, sorry.
I was just going to say, I mean, I think we have more and more patients that are probably living as long as they would have lived in the absence of transplantation, in the absence of liver disease. Just to finish my stories, I have another patient who turned 91 last fall. And we had a gentleman pass away at 93 a couple of years ago. So we're starting to see lots of octogenarians and even a few, nonagenarians as well. And I say to the patients all the time, we'll stop you from dying of your liver disease. So you get to die of the same things that everybody else does. Because the number one cause of death after a liver transplant, after the first couple of years and the dust has settled, is cardiovascular disease, heart attacks and strokes, just like everybody else. So what you say is correct. Blood pressure, weight, diabetes management, cholesterol management, regular exercise, hydration, and take your pills. That's basically what we ask.
Yeah.
Okay. A question that might be for either or both of you. Lisa is wondering, she's had a liver and kidney transplant now about 9 years ago, transplanted at age 49. She's been very stable and her health has also been stable, but she's never gotten her energy or stamina back. Is there anything that she can do to help with that?
I mean, I don't know the particulars of the case as well. I have to assume that I don't think she's one of mine. I mean, I have to assume that things like anemia have been addressed, that the medications have been appropriately examined and adjusted, that things like thyroid disease, other metabolic diseases have been ruled out as well. I mean, as I say, not everybody that's had a liver transplant.
One of your patients, Dr. Lilly, from 2014.
Yeah, I've been, as I say, I've been there for 3,800 transplants, and I don't remember them all.
Of course.
I mean, usually when that happens, it's not related to the function of the graft. Usually it's related to the list of other conditions that the patient suffers from. Even if patients have less than normal kidney function, it can cause some altered appetite, less energy, things like that as well. It's difficult to say more without recalling the specifics. But that's typically the approach that we would take. Start with just forget for the moment that they've had a transplant and look at the things that typically make women of her age feel the way that they feel, and then circle back around and see whether there's anything to do with the transplant or the medication she's receiving that might account for things. We can't promise everybody that they'll enjoy a normal quality of life. Over 80% of people do, however, after transplantation.
I'm actually going through that right now because my kidney function is so low and my hemoglobin is so low. So I have been very fatigued and, much less energy. And I actually just started RNS shots last week to try and put the hemoglobin up and give me more energy. And
they'll only push it up to about 100 to 110. You'll still won't restore it to normal. It doesn't usually do that. But you're right. But you're right. All your get up and go got up and left.
I did. But I've had so many wonderful years that, and it's because of what's happening now. Like if my kidneys hadn't got to this point, I'm sure I'd still be where I, feel as good as I did all along. So it's just the circumstances. But you're right. You do have to check everything because I think my hemoglobin is a huge factor in what's going on now.
Another question from Jacques for Dr. Lilly. Are you able to elaborate on the potential intraoperative complications for a patient with PCLD? Are there any patients that are at greater risk of those complications?
I'm not a surgeon, and they won't let me into the operating room. They let me drop my patients off at the door and pick them up on the way out. But no, the major complications that are unique to this disease are in patients that have had some sort of previous intervention. For example, the patient that we just transplanted a few days ago had previously had cysts drained, and there was a lot of scarring that resulted in the old liver being quite stuck in the abdomen. In fact, it's quite stuck to the diaphragm, and the surgery took much longer, and it was much more difficult for the surgeons to get the liver out. So I would have to say that otherwise, I mean, aside from the size of the liver and the fact that it's occupying so much space, it's mostly patients that have had some sort of previous intervention, particularly if they've had a liver resection, if they've had their cysts drained, if they've had their cysts sclerosed, if they've had their liver embolized, the scar tissue that is left behind will make the operation much, much more difficult.
Okay. And I think one of our last questions, also for you, Dr. Lilly, are there any variables between having a liver transplant from a living donor versus a deceased donor, and what might those?
Well, there are. I mean, we're lucky that we're able to offer both procedures to most of our patients. There are three principal advantages to living donation. The first one is the obvious one: it's faster. So if someone has liver cancer or has liver failure, and the prospect of waiting a year or longer on the waiting list is not one you really want to face in that setting. And it allows us, living donation allows us to transplant our patients sooner. The second thing is it's a very good quality graft by definition. So even though it's only a piece of someone's liver, it's in perfect health, and it was removed from the donor a few minutes earlier and packed up and walked across the hall, instead of a whole liver being taken from a deceased person, packed on ice and flown halfway across the province. And so the second advantage is a high quality graft. The third advantage for some of our patients is that they know in advance when they're going to have their transplants. They don't have to have the bag packed by the door and a whole series of people lined up to drive them into Toronto to do those things. The major limiting factor to living donation is size. When you take out 2/3 of someone's liver and give it to somebody else, you need to be assured that the recipient is receiving enough liver to replace their own, and while it grows back in about 8 weeks to 10 weeks. And you also have to leave enough liver in the donor. So there are very, very few patients who aren't eligible to receive either deceased donor or living donors. Exceptions include patients with multiple clots in their vessels, patients who are being retransplanted. There are a few other odds and ends as well. But the reason we've done 1,200 living donors, we've assessed upwards of 6,000 people. Aside from blood group incompatibility, the usual issues are donor size or donor anatomy as well. I think it's important, if someone needs a transplant, that they go to a center that actually offers both, because living donation has better results overall, because you're transplanting patients in general at earlier stages of their disease.
Okay. That was the last of our questions. Thank you both so much for all of your insight. There are a few very lovely comments in our question and answer box for Dr. Lilly and for Jan. Lisa is a patient of yours from 2014 who has said hi. Kim has said that she wants to thank you for the presentation, that you were her transplant doctor in March of 2015, and that she is in excellent health and her quality of life is wonderful. And she wanted to thank you for your excellent care. Kim also says thank you to Jan for sharing your moving story, and so much of what you shared she can relate to, and that she wishes you all the best.
Thank you. And
yes, Jacques also says that you are a hero, having undergone a kidney transplantation himself 22 years ago. He can barely imagine what you've been through, but thank you for the inspiration.
Thank you.
All right, with that, I will leave it over to Jeff to wrap up.
Thank you, of course, to Jan and Dr. Lilly for their incredible presentations, as well as their insight during the question and answer. I know that's always the most insightful part of our presentations. We do have a lot coming up here at the PKD Foundation of Canada, so I do encourage you all to stay connected. We're on all the major social media apps, and you can also find us at endpkd.ca and the French site finilampr.ca. We will have webinars throughout the summer months, and then of course our 3-day virtual PKD Summit coming up this fall. And excited to announce that on Sunday, we will be launching the registration for our Walk to End PKD campaign. So I do encourage you all to check out our social channels, visit the website, sign up for our e-newsletters to stay connected. We would love to have you at one of our Walk to End PKD events across Canada, or if there isn't one near you, there is also the virtual walk as well. So before I throw over to Anisha to close off the evening, Thank you to everyone who attended tonight's session. It will be recorded and we will be putting it up on both of our respective sites in the coming week or so. So if there's anything that you want to revisit, or you have someone in your life that you would like to share this presentation, we would love for you to pass along tonight's presentation. So thank you, Anisha, for this partnership and collaborative effort between the PKD Foundation of Canada and the Canadian Liver Foundation. It's been a pleasure to work with you as well, and I'll throw it over to you.
Thank you so much, Jeff. This has been very, very fun to be able to work with another organization and put on a webinar that I think is going to be able to help a lot of people. So we at the CLF have a few things coming up. Our next webinar is going to be in August, end of August, which is going to be another partnership of ours with Crohn's and Colitis Canada. So that's going to be focusing on both IBD and liver disease. So if you'd like more information on that, feel free to email me and I will be able to send you the details once those become available. And as well, if you'd like to stay connected with us, you can either find us on social media. We're on Facebook, Twitter, Instagram, or our website at liver.ca. Additionally, you can always email us any questions that you have about liver disease at clf@liver.ca. Thank you very much for coming, everybody.